editor with Becker's Healthcare. The program will begin with a presentation, and we will have a question and answer session following the completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have, and will follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time, but that email will not include the presentation. It is now my pleasure to introduce today's presenters. Molly Gamble is the editor-in-chief of Becker's Hospital Review. She oversees monthly issue planning for the magazine and assigns stories, creates and enforces deadlines, organizes the magazine's print layout, and heads development of the magazine's major lists. Ms. Gamble earned a degree in journalism with a minor in interdisciplinary peace and justice from Marquette University in Milwaukee. Then we have Mary Beth Mitchell, who is the Chief Nursing Informatics Officer at Texas Health Resources. Ms. Mitchell has 15 years of clinical informatics experience and was a hospital lead of a full EMR implementation, including CPOE. She has experience with implementing and maintaining many systems, including wireless communication. She has a passion for using technology to improve patient care by making resources and information easily accessible to clinicians. She holds a master's in nursing from UT Austin and a master's in nursing informatics from Duke University and is a registered nurse. Then we have Rhonda Collins, who is the Chief Nursing Officer at Vocera Communications. Ms. Collins is responsible for working with nursing leadership groups globally to increase their understanding of Vocera solutions, share clinical best practices, and to bring their specific requirements to Vocera's product and solutions teams. Prior to joining Vocera, Ms. Collins led the American Nurse Project, elevating the voice of nurses across the country. Through her previous experience at Baylor University Medical Center as Vice President of Women and Children's Services, Ms. Collins has a deep experience building on clinical and business best practices. She holds a bachelor's degree from Texas Tech University, a master's in science nursing administration from University of Texas at Arlington, and is a registered nurse. It is now my pleasure to turn the floor over to Molly Gamble to begin today's presentation.
Thank you so much for the introduction, Heather, and thank you to the attendees for taking some time out of their busy days to join us for this discussion. So the topic we're talking about today, nurses' ability to spend time at the patient bedside, is really a pressing issue that's receiving a lot of attention. So this is the day and age of hospitals being forced to do more than less. You hear that quite often. But before attempting that, hospitals must first do better with what they already have. And what they already have is a staff of nurses who work very hard, are highly committed to their patients, and really want to spend time on the things that make the biggest difference to the patient, his or her outcomes, and how he or she feels about the hospital stay. So now the challenge for hospitals is how they can help their devoted nurses work better. Rhonda and Mary Beth, as nurses themselves, have plenty of insight and experience to share about the role of nurses at patient bedsides. And from the broad news perspective, the role nurses play in patient outcomes, safety, and satisfaction could not be more evident. People are admitted to hospitals because they need around-the-clock attention and care, but studies have shown nurses may spend less than 2 hours of a 12-hour shift on direct patient care. Nurses are spending a significant portion of their shifts instead paging physicians, copying and faxing documents, tracking down test results, searching for supplies, completing paperwork, a lot of other tasks, a variety of tasks. So they are very, very busy and they work very hard, but many hospitals are really realizing their nurses are not spending enough time with patients, and this is problematic. That's the time that really matters the most. Studies have shown the more time nurses spend at the bedside, the less likely the patients are to experience falls, infections, and medication errors, and the more likely they are to leave satisfied with the care they receive. Next slide, please. So as hospitals make a dedicated effort to increase the amount of time nurses spend with patients for the patient experience and for those outcomes, they must also defend how nurses interact with patients. So one question you can ask is, how often are nurses interrupted? This is a big problem. The more frequently a nurse is interrupted while administering medications, the greater the risk of error. A 2010 study found 4 interruptions in the course of a single drug administration, double the likelihood of a patient experiencing a major error. Interruptions occurred during more than half of all administrations that were studied, and each interruption was linked to a 12% increase in either procedural failures and a 13% increase in clinical errors. Studies like this illustrate the sensitivity and the importance of what is really one of the most special relationships in healthcare, and that's very evident to the entire editorial team from the stories we cover every day. And that relationship is the one between the patient and the nurse. The way nurses work and the way patients heal are strongly connected and dependent upon one another. Rhonda and Mary Beth have a wealth of expertise, experience, and insight to offer about this. I'm really looking forward to the discussion it's going to entail. So on that note, I will let Rhonda continue the presentation now with her clinical perspective.
Thank you, Molly. I appreciate this opportunity to have this conversation with Mary Beth, with you and the listeners and attendees of the webcast. We're excited to be able to open up and have this conversation. And in light of that, we want to ask you to participate. Our next slide is a poll question, and we would like to ask you to take this, answer the question for us, and we can actually see the results in real time. If you would go ahead now and just let us know how important is a secure communication strategy for your organization right now. And let's see. Do we have the results coming in? And here we go. If the numbers are still climbing, and you can see that well over 50% of you are considering this a high priority for your organization, very few say not at all. So I think that what we're talking about today is a timely conversation. It's one that we all are focused on in finding the best strategy. And as Molly said, my role with Vocera is working with nurse executives and nurse leaders across the country, really globally, to determine how do we define strategies that are sustainable. And nurses do not work in a closed environment. Nurses work with extended caregivers, work with physicians, everyone to ensure the best experience for the patient. So 57% of you say that it's a high priority. Absolutely. So let's talk about extending communication to the community. When evaluating a communication strategy or needs, both inside the acute care hospital and outside, the challenge is to simplify and coordinate a solution that makes it seamless for those who are mobile. And by mobile, I mean those who move around in the environment that we're in. And I think all of us can agree that we don't stay in one place. I've actually heard this in a commercial on TV, but I've been saying it for a long time, is technology is static and stationary. You are what is mobile. And you define your work environment, and you define exactly how the technology works for you in your work environment. The vision is that communication follows the patient. It doesn't start with a device. It doesn't start with a technology platform. Communication starts with the patient. And the patient then enters the healthcare system either through a physician's office or through the ED as a direct admit. And likewise, the caregivers all have to be talking to each other or communicating with each other in a seamless environment. So we are focused on bringing that same communication strategy or layer so everyone is talking to each other in a secure, seamless fashion, using the same nomenclatures, the same process, the same workflows, no matter what device they use. Not at all. Next slide, please. So here are some of the challenges that we face. 96% of physicians with smartphones use unsecure SMS for patient care. Now, what we're talking about is they are usually texting each other, sometimes asking for a consult, sometimes giving information to their colleagues to take over call, sometimes moving through their own.
Anytime for 2:30, is that what she said? Yeah, but she gave Eastern time.
I
can do 1:30 our time. I have an interview at 1, but it shouldn't take that long. Yeah.
You're not on mute. Thank you. Heather, I don't think you're on mute.
Sorry, that was me, Rhonda. I am now.
Okay, thank you. So when we look at 96% of the physicians using their own personal phone for patient care, and we're talking about nurses in this particular presentation, they are primarily texting each other, but secondarily, they're talking to somebody else, and that is usually the nurse. So 89% of hospitals report that they do not allow their nurses to use their personal smartphones, but some intrepid nurses anonymously admitted to, and in a survey and a study, 67% of nurses do so anyway. There was a report that just came out this week that talked about nurses do use their smartphones to look up information, drug information, et cetera, while on the job. But as far as communicating with physicians, this is what they do because it is ubiquitous to their personal life, and their personal way of managing business is to use a smartphone or a mobile technology. The Joint Commission says 80% of all medical errors are linked to communication failures. Communication failures are defined as an absence of, entirely missed, or a miscommunication. When 80% of all medical errors are linked to the fact that we are not ensuring that information is relayed across the systems appropriately, it becomes a problem. Which leads to the next slide, that when we talk about communication breakdowns, of that 80%, communication breakdowns then become the cause of U.S. hospitals. There is over $12 billion wasted annually in our hospitals with communication inefficiencies. And we have spent, this is probably a very conservative number. The number is escalating exponentially, but $50 billion last year to purchase, install, and deploy EHRs and clinical systems and IT services to try to solve this problem so we can communicate effortlessly across the system. There is nothing that can take the place of just a conversation. I think that conversations are incredibly important, and I think that we all agree that sometimes messaging is missed, sometimes it's misunderstood. So to be able to have the ability to message and or talk to each other is the preferred method of communications. Next slide. So if you look at communication solutions, I never start with a device. When I talk to nurse executives all across the country, we talk about workflow. How does the nurse work? How does the nurse care for their patients? How do they move in and out of their environments? What makes the most sense for them? So with different clinical roles can sometimes come different device needs, whether it's a physician using their own personal smartphone, whether it's using applications on an iPad that allow nurses to make assessments and to generate information that flows through the EHR, or it's that instant communication of having hands-free wearable device. That is what is important in determining a communication strategy. I know that in healthcare we are very committed to standardization, and all of us who have been in healthcare for a good long while know that standardize, standardize, standardize has been our theme for a very long time. So there is a tendency to think we have to standardize a device, and in reality, standardizing a device is not a reality, because everyone has a different need. Everyone has a different approach to how they work in their environment. What you standardize is the software. So all of the devices work in the same software, whether you're hands-free or whether you're using a tablet or phone. I usually liken it to email. All of us have an enterprise email platform, but very few of us only answer email sitting at our PC. Some of us sit at our computer working on a document and answer email on our phone. I'm one of those people. And so I can tell you that you follow the workflow. When we evaluate how nurses work, it's as varied as you can imagine, and it always works in the environment to give them the tools that they need that don't disrupt their process. Next slide. So the focus of communication and standardizing a communication platform is returning people to their purpose. We've talked about this quite a bit, that hospital nurses spend only 20% of their time delivering care at the patient bedside. Our goal is to ensure that nurses are able to spend the time with the patient and not have to leave the room. When a patient complains of pain, the nurse can respond immediately from the bedside to contact their provider, their physician, without having to go out to the desk, leave the patient, then come back, and all those increased steps and workflow processes. I think that when we're able to do that, we can increase the satisfaction of those who are working in the environment, the satisfaction of the patients, and certainly find a solution that delivers a long-term strategy that enables everyone to work in the ways that they are mobile, rather than us defining how to be mobile. Having said that, I think at this point we are transitioning over to Mary Beth.
So you can go to the next slide. This is Mary Beth Mitchell, and I am the CNIO for Texas Health Resources. And I just want to give you a little bit of information about THR to put in perspective kind of our scope. We have 25 hospitals in the North Texas area. 14 of those hospitals are wholly owned and are all on the same instances of most of our technology, including our EHR and communication, as well as staffing and scheduling and all of our business applications. We have many outpatient facilities, and oh, I don't see this on here. One of the things I do want to point out is we have about 7,500 nurses that are taking care of patients, direct care nurses, and about 5,500 physicians. And that really makes up a lot of our workforce in terms of communication and some of the things I'm going to be talking about. The other thing I want to point out is, you know, we have 5 magnet hospitals where we have 11 of our hospitals are stage 7 at HIMSS Analytics. We've won the HIMSS Davies Award, and we've won the CIO a Year Award through Chime and HIMSS. And the reason I point that out is we get a lot of accolades, and we're very proud of that, but we still have the challenges and the issues that have been talked about and that Rhonda was talking about. We haven't solved all of the problems, and, you know, our strive for excellence and trying to be better and better, we still have a lot of the same challenges that are being discussed. So if you can go to the next slide. This is how I see communication. You know, yesterday things were pretty easy. You had the patient talking to the physician, patient talking to the nurse. You had simple, pretty much one-way communication. If you look at the bottom half of this slide, there is so much more integration of communication and so many different pieces involved. And how do we make sure that we are communicating to the right system, to the right person, that the communication is two-way or multiple-way? I don't even know how to break this slide down and say how we manage those. And I think some of it goes back to what Rhonda was saying around workflow. But just think of your staff in your organizations and how they know and how they make the decisions of how they're going to manage all of this communication, what tools they're going to use, and who they're going to communicate to, and for what purposes. I think it's just more and more complex, at least in my life it is, and in our organization. The next slide, please. So I'm going to talk a little bit about some of the challenges that I think we face around communication, and certainly these are challenges that we face in our organization and in our hospitals. The first one really is over-reliance on technology, and I've done a lot of work around unintended consequences and the safety issues that come about when we think we're doing the right thing and when we're trying to do the right thing. And one of them that constantly comes up is this over-reliance on technology. Somewhere in putting our EHRs in and our very sophisticated systems to make life easier, we have lost the ability to talk to each other. We've lost the ability to communicate. We think things are happening and that a lot of our systems are taking care of the communication. We think when we get an alert that people are responding to that they're following through on the communication needs, that we think that we're sending messages and that we don't have to follow up on those messages, and really that the technology is managing a lot of our communication needs. We also are faced with a lack of standard communication strategy. Are organizations really looking at communication as its own strategy, or is it just a byproduct? Or do we think it's just going to kind of happen as we move forward with the various other strategies? And I think, and I'm going to talk more about this in a minute, that we really need to manage communication as a strategy. It's a component of our other initiatives and things that we're doing, but a lot of times it kind of falls to the bottom of the list, at least in our organization. And then another problem we have around communication is we have multiple devices. And this is something I still struggle with trying to get my arms around. You know, we still have hundreds of pagers in our organization, and I thought we had gotten rid of pagers. And when we did a evaluation, we have hundreds of them. And many of them are in drawers and not being used, but we still have high utilization of pagers. We also have wireless communication devices, such as the Vocera badge, and our nurses have those devices. We also have our smartphones, and we communicate through those. We are one of the organizations, many of our hospitals do not advocate nurses using their personal devices for communication. You know, there's still a perception out there that if patients see a nurse on their smartphone, they're thinking they're on Facebook or doing something personal rather than that they may be using it for work-related communication. So we haven't really gone there yet with the smartphones for communication, but we also know that our nurses are carrying their own communication devices, their own smartphones and those things as well. We also know, I know we experience texting, the unsecured SMS texting, and this is why I voted that communication is definitely a high priority for me, because I'm very concerned about the use of unsecured texting. And I personally don't fault anybody for doing that. They are trying to be efficient. They're trying to take care of patients. They're trying to get through their day. And we need to give them the tools to do that effectively, or they're going to find ways to do it on their own. So I am very concerned about texting and the use of unsecured texting. And then also we have delays in callback that can result in delays in care. So when we put in a page or when we call a physician, a nurse calls a physician waiting for a callback, that delay in that callback can result in delay in care. And we see this around, one couple of things that come to my mind is one nurse may call a physician and then that nurse leaves before the physician calls back, or that nurse goes somewhere else or is involved in something else. And we even have problems getting the calls back. And then also the lack of understanding who to call. We may not know who's on call. We may not know if people are on breaks or the staff changes. And we need better ways than to have a name of a person of who to call or to call back. So those are some of the challenges. So what do we do about these challenges? Let's go to the next slide, please. And I think there are several things that we can do and to bring these communication pieces together. I'm not saying that we have done them, and we're still certainly a work in progress, but I believe Texas Health is kind of headed in this direction. To have a clear strategy for communication, we've created a unified communications program that we're really looking at what is our strategy for communication and pulling together all of those random parts and what's working and what's not working, and how do we take those best practices and hardwire those across all of our hospitals and get rid of the workflows that aren't working as well. So really defining and being very intentional about that communication strategy. Also going from a person-specific to a role-specific method of communication. Like I said a minute ago, when you call a certain person and leave a certain person as a callback, those things can change, and it's often hard to find out who it is you need to talk to and who they need to talk to when they call back. So let's make it about the role and not necessarily about the person, and how do we manage role-specific communication. And then you need the flexibility to manage escalations, changes in staff, emergencies, and things that come up. And I want to give you an example. Our Chief Innovation and Integration Officer, it's a new role we've created, and her name is Wenji Mayo Tang, and she was a CEO at one of our hospitals. And they have invested in that hospital heavily in the use of communication devices. So they have wireless communication devices, the Vocera badges that the nurses wear, and then also they have secure messaging and other tools that they have on their smartphones. And they have developed a very clear strategy for managing escalations. And she gives this example of a nurse goes into a patient's room, or I'm sorry, a patient calls the front desk and needs an extra pillow. So the unit secretary at the front desk uses the communication device to tell the nurse that they need a pillow in room, Mrs. So-and-so needs a pillow. As the nurse is going to get that, she gets pulled away to another emergency that's happening. If she doesn't respond with that pillow in a certain amount of time, that request automatically then goes to someone else, maybe the patient care technician. If that patient care technician is headed off to get a pillow and somebody calls her and needs something else and she gets distracted, then that call goes to someone else, and so on, and it keeps escalating it. The CEO of the hospital said she fully expects someday to get a message on her phone through Vocera saying that she needs to go get a pillow for the patient in whatever room, and that she's not thinking that nobody else is doing their job, except that she's thinking everybody else had other things to do and the system worked to escalate that message. So that's an example of how we can manage escalations, and I think that is really an area that we can enhance through our communication tools. And then also the ability to integrate various technologies for communications. We know that not one size is going to fit all, and we need to, in our plan for communication, look at how we can manage the various different kinds of technologies. So it may be a nurse wearing a wireless badge. It may be a manager using a smartphone. Certainly we are looking at secure messaging and having shared devices. Our plan is to have shared devices where a nurse would pick up a smartphone when they come on shift, log in, and be able to message, be able to communicate, be able to place calls. And when we're talking about the integration, also to be able to integrate communication into our EHR or other systems where we need to communicate. So if I'm in a certain patient's record and I notice something and now I need to make a call to that physician or send a message, I can do that from within the patient record directly through my communication device. I don't have to go out and get another device, and I have the information right there I need. And I will say I am a big proponent for secure messaging. I think that is really going to be a game changer for us. We're starting to implement that now. And the things that we'll be able to do, especially from working directly within the patient record to send those messages and get those responses back. We're getting ready to kick off. Well, we've done our kickoff already. Our pilot's about ready to go live with secure messaging. And also the ability to send images across secure messaging. I think that's going to be very important as well. We know that clinicians are sending images through text today, And I actually think that we need to do more to encourage staff being able to do that. Instead of saying no texting, giving them the tools and saying, we want you to send this image to the physician. We want you to communicate directly to the physician via messaging, but you need to do it through these tools. The one thing I do want to add about messaging, and I don't like to call it texting. To me, texting is unsecured. I like to use the word secure messaging when I'm talking about using these tools. But I lost my train of thought. Oh, well, anyway, let's go to the next slide. Okay. So here's kind of our approach to communication. We have standardized tools, and we have really used the Vocera badges for a number of years. And those are basically for point-to-point notification. And so somebody calls another person with their Vocera badge who also has a badge. We also have the ability to escalate and establish role-based call paths, as I mentioned before, the CEO of the hospital getting a call that they need to go take a patient a pillow. Like I said, we're putting in the Vocera collaboration suite for messaging. We will be doing secure messaging. And the other thing is that this can help manage our physician call schedules. And we're using this today with all of our hospitalists, where you may not know as the nurse which hospitalist is covering for that patient. And so we can put in the message, and it doesn't matter which physician, it will automatically go to the physician on call, and then that physician can call back. I know what I meant to say that left me. I want to just be real clear. We are not allowing the receiving of orders from the physician via messaging. So we've made that very clear that nurses cannot accept physician orders via message, not even secure message, because we have no way to provide the readback. So right now we're not allowing for orders. Maybe someday in the future, as we get better at this and as this technology advances, we might allow it then, but right now we don't. Also, we need defined guidelines and policies for communication management. So we're starting to work on those policies and really to lay out the plan, the strategy, the policies around communication, the guidelines, when you can use messaging, when you can take photos, how you manage sending those, what you can do with them. For instance, if can a physician take a image that is sent to him and import that into the electronic health record. Those are some of the things that we're trying to make decisions on and how to manage those in our through our policies. And then the management of personal devices versus shared devices. We are definitely, for our staff nurses, looking at shared devices at this point. And we're also having to develop some scripting around how to communicate to patients that these are clinical tools and not personal, not for nurses' personal use, but they are clinical tools. We also hope to use our devices for multiple things, whether it be barcoded med administration, communication, placing calls, sending messages, or looking up resources and looking up information for the care of their patients. I think that's becoming the smartphone is becoming a clinical tool. And then making sure we have enough access and availability of tools, who gets the tools, how they check them out, how they're maintained, how they're managed, those kind of things. And then the integration with other systems. I already talked a little bit how we integrate these with our electronic health record. The other thing I'm really interested in, and this is becoming another big component of this whole communication strategy, is around alarm management and the management of fatigue and how we can use these tools to divert certain types of alarms, to get rid of nuisance alarms, and to escalate those critical alarms appropriately. Next slide. So I feel that if we have a strategy and if we have the right tools and if we have the right ways to communicate, that we can conquer this beast and really make a difference and show good outcomes. That's the next thing I'm really hoping to do as we get these systems in, is to really look at our clinical outcomes related to communication. We're looking at adverse events related to communication and starting to say, what are those best practices and how do we get those, more fully developed. So with that, I think I'm going to turn it back over to Rhonda.
Okay, thank you, Mary Beth. As always, you're a very articulate expert voice for us in this arena. All of us in nursing appreciate you and others who have focused on informatics to ensure that the clinical process at the bedside is sustained and is valued and also is heard. So we appreciate your insights in telling us the story of Texas Health. Next slide, please. So I think what we've been talking about, both Mary Beth and I have been discussing, is clinical communication is a strategy, and it's not just a one decision to solve a one problem. It is a long-term platform. It's a long-term strategy. It is ensuring that you can work with multiple devices in the same software environment to understand the workflows, to understand what is needed, because I think that when technology takes on the task of changing practice, there's a likelihood that the success is going to be, or the adoption will be very low. I think when technology takes on the task of enhancing practice or streamlining a process, the incidence of adoption and full use is very high. So those of us who are involved with technology and nursing practice and how we look at this is what we're focused on, is that absolutely at Vocera we're focused on reaching the right person instantly at the right time on the right device with the right information in the right place. I think that is what a full and robust communication strategy entails. We thank you for your time and attention and attending today. And we're going to open it up to questions now. So if you have a question, if you could go ahead and type that question, then we will answer those and make sure that it gets to the right expert for you. Heather?
Yes. Thank you, everyone, for that informative and enjoyable presentation. As she mentioned, we will now begin the Q&A portion of the program. As a reminder to our attendees, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We'll attempt to answer as many questions as we can during the time we have and can follow up on questions we don't have the opportunity to address. To start, this question is probably best for Rhonda. How can we connect our nursing staff with not only our employed physicians, but also the physicians who are affiliated with our health system? Those doctors are not in our hospital directory database.
It's actually quite easy. Physicians almost always will use their own personal smartphone. And if you have a communication solution that works off of an app-based environment, then the app goes on their phone, and the physician can just work through the app, and the conversations, the messaging is all secured, and they can then contact folks inside and outside the hospital. Does not require the phone to be on a Wi-Fi network. The phone can be both cellular or Wi-Fi.
This is Mary Beth. Without having the messaging and the app, what we've done is the nurse will call the doctor either on their phone or to their pager and leave their Vocera badge number to call back. Or the physician can call the central Vocera badge number and then start using the Vocera commands, asking for what a nurse or a floor, those kind of things. So we can use it, basically in the same way that we use the telephone.
Perfect. Thank you, Mary Beth.
Great. Thank you both. The next question might be for Mary Beth. From an informatics perspective, what are the key clinical systems you oversee, and how do you prioritize those that THR will invest in?
What are the clinical systems? Oversight, I really oversee how nurses use the system, so I just want to clarify I'm not responsible for the teams that manage these systems within IT. So I'm very heavily involved in the EHR. I'm also very heavily involved to some extent in communications, staff scheduling, IV pumps, those kinds of things. But I think as far as prioritizing, it's like being a nurse, right? It's on any given day, at any given moment, the priority is whatever's staring me in the face. So I think we have different organizational priorities, and that's probably where I spend a lot of my time is on our strategic focus and our strategic initiatives and how we can advance nursing practice and clinical outcomes and patient outcomes through the use of our technology tools. So I don't know if that answered your question, but that's kind of how I see my role, is making sure I'm representing the patient at the forefront through the clinical experience and how we can use whatever tools are at hand to meet those needs.
Great, okay.
And,
go ahead.
No, I was just going to say, it's a lot of fun. It's like being a nurse. Every day is a different adventure.
All right, another question for you, Mary Beth. How do you manage communication flow, such as secure texting or voice calls, based on the real-time staff availability, such as last-minute patient assignment changes, lunch breaks, or people who call in sick?
Yeah, and a lot of that, I want to say I oversee things at a macro level, at a strategic level, so it's hard for me to really know how each unit manages on a day-to-day basis. But one of the good things with these communication tools is that when you come onto a unit, you pick up a device and you log in. So it doesn't matter if you float, because you're logging in to your location and the device you pick up. And so I think it has a lot more flexibility than your own personal phone. So when that physician calls that unit, they don't have to know that you're afloat and where you came from and what your number is, just that you're logged into that unit and on that device. And I will say our staff are very good about logging into the devices. And let me take a moment. This is one of my biggest concerns and biggest challenges, is how many places our staff are having to log in. They log into the EHR, they have to assign themselves, not log in, but how many places they have to make their assignments. They have to make assignments they have to identify themselves in the EHR, what patients they're taking care of. With Vocera, they assign themselves to a group of patients so that whoever's calling knows, like I said, they don't have to know who the person is taking care of Mrs. Smith. They just have to know Mrs. Smith, and it automatically calls that Vocera badge. They also have to log into teletracking, to our staff scheduling system. So I hope in the future we will have more integration between these systems so that we are not having to make our assignments within every single one of these systems. And I think we're starting to see that. I mentioned a little bit the integration between the EHR and our communication devices, and I think that's a start that we will see more of that integration and start getting that if I have assigned myself to a group of patients within the EHR, then my Vocera badge knows that, my smartphone knows that, my schedule knows that, everything knows that. So anyway, I just went down that rabbit trail, but that's another area where I feel we're really putting a lot of burden on our nurses having to make assignments in all these places. But it's very good. It's very good with communication that I can make an assignment and say I'm taking care of this patient, and then everything kind of rolls seamlessly from there.
Okay.
Great, thank you. Got a question here for Rhonda. With Vocera in place, how much more time does the nurse now have at the patient's bedside?
That is a question that I'm not sure I can answer in an absolute metric. I can tell you that we have use cases that tell us that nurses are spending more active time. We do hear from patients, actually. We heard from a patient last week to say he had been a techie all his life, and he was fascinated with this small device around his nurse's neck, and that she was able to instantly communicate and never leave him, and that he felt like he was attended to in the most remarkable way. And he he actually was so impressed with how much time his nurse was able to spend with him that he sent us a note about that. So I would like to be able to answer your question with a metric. I can tell you that our use cases tell us that the nurse time is greatly improved, that the patient response, patient satisfaction is, we can document that patient satisfaction goes up when the nurses are able to respond directly from the bedside rather than making multiple trips to the nurse's station or back and forth to a landline phone.
And this is Mary Beth. I just want to add, I don't know how much time we save. I think we've gained some inefficiencies because the communication's gotten so much more complex. I can't imagine how we could do communication like we used to do when we were only calling a physician or only calling one person. The integration, like that slide I showed, the integration of communication between multiple systems has to be managed somehow. So whether it's through efficiencies or time, I think both are important.
Thank you, Mary Beth.
Great, yeah, thank you both. Mary Beth, here's a question for you. How many smartphones do you have installed today for nurses or staff that are at the point of care?
I don't know. We have, our model is our hospitals buy those through the hospital-based IT departments. I started to give a glib answer, probably about at least double what I think we have. We constantly are ordering new badges. We're ordering new devices. We are just starting to roll out the smartphones for clinicians. So we have very few of those today, but you know, I expect the trend to go to more and more smartphones and fewer other devices. But right now, we're not using a lot of smartphones. That's just now coming. We have lots of badges, lots and lots of badges, hundreds, thousands of them, I think.
Great, okay. Related to the badges, a question for Rhonda. What would be the fallback if someone is not wearing their Vocera badge or it is not available?
You know, using and wearing a badge does not preclude you from using a smartphone. Nurses or caregivers all over can use either or both. It doesn't matter. So if you're talking about a Vocera solution, it's yes to everything. The fallback, if a nurse doesn't have a badge, you know, we do a lot of call flows and look at how folks are operating in their current environment, and frequently it's a call, what I would call a broadcast call from the nurse call system. Kathy, what room? So somebody can then hit the panel in the room they're in and say, yes, I'm in room 14 or whatever it is. There's multiple ways that hospitals function. Some of them are very elaborate, some of them are very simplistic. And those are, what we try to do is look at all of those workflows, look at how many steps the nurse goes through just to get assistance or help at the bedside when they need it versus, you know, a hands-free wearable such as the Vocera badge to be able to call for help or to be able to respond immediately and say, yes, I'm right here. So the fallback system without the Vocera badge is the standard, what I call and hunt process of looking for the right person. When we do clinical assessments in hospitals to look at what their current process is, always the primary ways hospitals are communicating with each other, there's top three. There's always the landline, there's always overhead paging, and then one that seems to bubble up frequently is calling out for help, or as some put it, yelling. You know, just saying, hey, I need help in here, or sticking their head out a door. So those are all the standard ways that nurses in their current work environment have to function simply because there's no other option. So with the Vocera badge, of course, or with the phone, it doesn't matter, either or both, the nurse is able to contact directly who they need to contact in the moment.
And I think every unit's different. We have some units that do really well with Vocera and some units that don't hardly use it at all. And we have some units that use an intercom system more, and some units that never use an intercom system. So a lot of it is the independent individual units and how they function. I think that's why having a strategy and policies are really important, because we want to take those best practices and roll those out everywhere. But today, it's all over the place.
I agree, Mary Beth. We see that in hospitals all over the country, and every unit is its own culture.
Yep.
Great, thank you both. I have a question here for Mary Beth. How do you encourage your medical staff to comply with the new security policies when utilizing technology devices?
Well, I don't know, and if you figure it out, tell me. You know, I think the medical staff they've had the same concerns that we have in nursing. They want to be safe. They want to have good clinical outcomes. If we give them the tools and the opportunities to do the right thing, I think they'll use them. And so if we can get the Vocera Alert widespread and make that available for physicians and use that as our standard way of messaging, then I think they'll use that. And not everybody, not all the time, but I think one reason why we see this unsecured texting is because we haven't given them anything better and more efficient. And texting is a tool that they use all the time now anyway, and so it's easy to translate that into using it at work. And I text at work. I don't deal with PHI, but I text my staff. And so we need to make these systems work for us and make it as easy to do the right thing as, you know, doing whatever workaround they've come up with. But a lot of our physicians now are, and I'm sure this is the same in many organizations, we have a lot of employed physicians, we have a lot of hospitalists, so we see less attendings that are external to us. We still have a fair number of those, but we have a lot more physicians that are within our organization that, you know, are they're more likely to use these tools as well as we roll them out. But we've got to get them out to them in a way that makes sense.
That makes sense. Thank you. Got another question for Mary Beth. Could you please elaborate more on the resources you use to educate patients about the use of devices for communications?
Yeah, that's a work in progress too, because we're trying to develop some messaging. I hate to say scripting because that sounds so rote, but we're trying to put together the messages that we want staff to explain to patients how they use the various devices. And a lot of that is being done through our nursing informaticists and our nursing informatics super users and people, those kind of folks, to help develop what the communication is that we want to give patients. We've also done not so much around communication, but we've also got some like table tents that we can put on there. We have patient admission brochures, and it does speak to communication in the patient admission brochures on just what kind of things to expect. But it's not just around communication, it's about the whole use of technology. You know, as we're rolling a WOW into the room to do an admission on the patient and we're doing it straight into the computer, to have those kind of messages of how we use all of our tools and those kind of things. I think it's interesting though, I've started seeing a shift. Patients expect these advanced technology tools now. They're less intimidated by them, and I had a patient at one of our hospitals when the nurse came in with the WOW, kind of looked back and said, oh my gosh, that's old technology. You know, their patients are expecting us to use smartphones and tablets, and, you know, they're not put off by those as much anymore. Even my 87-year-old mother expects, you know, her physician to be using a tablet.
All right.
And she'll pull out her tablet. Yeah.
It looks like we have time for about one more question. This one, maybe Rhonda can take it. Some older hospitals have significant dead zones. How will we address this? We've been told it's a bandwidth issue.
Obviously, it is an issue for the hands-free communication because you have to have a sustainable Wi-Fi or wireless network. I think that as hospitals age, and obviously I've come from hospitals where one of our buildings was over 100 years old and then the other building was 15 years old, and we were constantly challenged with how do we make wireless technologies work throughout the entire facility. So that is an ongoing problem for some hospitals, and it's something that you have to commit to doing the infrastructure changes that you need to do to sustain the technology. And wireless is here to stay. It's not going anywhere. So most hospitals who have dead spots, there's strategies that can happen. Obviously, Vocera has professionals. You know, we have technical specialists who can come in and do a full assessment of facilities and make recommendations, because a lot of what we do is not just entirely, you know, just providing the products, the software and limited hardware, but what we do also is to function as subject matter experts and as the SME provide clinical guidance, what we see from experts like Mary Beth all across the country, or professional guidance on technical aspects and needs for the hospitals.
And I agree, it's an issue, and we've had a lot of discussions around this. And the more, I think, the more you start using mobile devices, the more those network inadequacies are exposed. And you have to have the commitment to maintain that infrastructure and constantly be updating and you know, adding to that infrastructure. And it's a real difficult place to be. We have those challenges all the time.
Yeah, I think most hospitals have those challenges across the country, just because we cobble together buildings over decades and centuries that have a real challenge with it.
And the staff learn where those dead spots are pretty quickly, and they learn how to work around those dead spots.
It's like in your house. You know where your cell phone doesn't work.
That's right.
All right, great. Well, on that note, I want to again thank Mary Beth, Rhonda, and Molly for the excellent presentation, and for all of the attendees for participating today. As a reminder, you will receive a follow-up email after the event in about a week with instructions on how to view the webinar materials. We look forward to having you join us for future webinars. And that concludes today's program. Have a wonderful afternoon.